Hello, this is the continuation of our discussion on diagnostic studies for gastrointestinal assessment and care. Now, let's talk about scintigraphy. We have been talking about diagnostic studies. Now, we are talking about imaging studies like your CT scan, MRI, your PET, and then you have your scintigraphy. When I say scintigraphy is using your radionuclide imaging. Okay, so meaning there is a use of radioactive isotopes. However, these radioactive isotopes are deemed to be not harmful to the body. Okay, it's just short-lived inside the body. So it is used to evaluate changes in organ size, meaning it can be used for early detection of abnormal growth inside our body. It is used for detection of neoplasms and cancer. In some cases, it is used for the radioactive tagging of your RBCs. In radioactive tagging of RBCs, this is done when your patient is receiving a lot of blood transfusion and then your patient's hemoglobin, hematocrit, and RBC are still low. So, the clinical practitioners may be wondering where are all the blood transfusions going. So, if we are not yet sure if where are the blood going, if where the bleeding is, your radioactive tagging with your scintigraphy may be done. Then, we have your virtual colonoscopy. Virtual colonoscopy is a new emerging technology which involves performing a CT scan and then reconstructing the entire CT scan images to form a three-dimensional colonoscopic image. Okay, it's as if the scope is inserted inside the patient's body. So, virtual colonoscopy. It's referred to as virtual colonoscopy because through a CT scan, a 3D image of the colon may be formulated or may be formed that can be used to evaluate its specific parts. Now, let's talk about your upper GI tract study and your lower GI tract study. For the upper GI tract study, so we're using fibroscopy and then barium swallow. Whereas for the lower GI tract study, we use your barium enema. So it's referred to as barium swallow because you're swallowing it. It's referred to as barium enema because it's inserted through the rectal orifice to travel towards the intestine. These are images of patients who have undergone barium swallow. So on your left, you can see a patient with an obstruction at the lower end of the esophagus. So this patient is a pediatric patient. As you can see, there is a narrowing here, which would indicate an obstruction on the lower end of the esophagus. On the other hand, on your right, you are seeing a patient with achalasia. So when I say achalasia, the LES or the lower esophageal sphincter fails to open up during swallowing. So supposedly, the lower esophageal sphincter needs to open up after swallowing, and the purpose of that is for the food from the esophagus to go to the stomach. However, in a condition referred to as achalasia, there is failure of this LES to open up, and hence there is dilatation of the upper part of the esophagus because of the backflow of the food that is being taken by the patient. Now, so these are sample images of a patient with who have undergone barium swallow, So prior to the barium swallow procedure, the following are needed. One, your patient should be maintained in a clear liquid diet. Second, your patient should be NPO post-midnight. Whenever we are doing imaging studies for the gastrointestinal tract, usually the patient is placed on NPO. Also, the patient would be advised not to smoke and not to chew gum because it would increase acid secretions. Then you need to be mindful. Since we are talking about gastrointestinal problems already, if you're placing your patient on NPO and then your patient is a diabetic patient, you need to counter check that the insulin dose of the patient is readjusted. Why? If your patient is placed on NPO and then your patient is on insulin, you are increasing the risk for your patient's hypoglycemia. So you need to watch out for that. That will be applicable to all patients who are on NPO and then patients who are diabetic. Then we have your barium enema. So your barium enema is used to visualize the large intestines, and the purpose of that is to determine the presence of polyps, tumors, and lesions. So this is an example image of a barium enema. Okay, this barium enema looks normal. Uh, the preparation would include bowel preparation, which means that you need to cleanse the bowel prior to the procedure. Okay, cleansing the bowel would include having, low residual diet for 1 to 2 days. So when I say low residue diet, okay, decrease fiber in the diet, okay, decrease fats in the diet for 1 to 2 days. Then you need to have clear liquid diet, okay, the night prior to the procedure, and then laxative is also given to the patient the night prior to the procedure, and then NPO post midnight. What we are doing to our patient is enema until return flow is clear. So when we say enema, meaning we administer the enema until what comes out of the anus of your patient are already clear liquids. Okay, we cannot proceed with the procedure if there are still some substances or fecal matter that goes out with your patient's anal orifice, because that would indicate that the large intestine is not yet clean. There are still residues remaining in the large intestines. So there are two common kinds of enema, your soap-sud enema and your fleet enema. At present, the ones commonly used in the area is already your fleet enema. Okay, so when you administer this enema, tendency is for the gastrointestinal tract of the patient to be irritated in such a way that it will trigger the patient to defecate. And that will clean the gastrointestinal tract of your patient. Then we have your, still this is an image of barium enema. So it shows how the barium liquid is being inserted. So usually your patient is placed on the left side, okay, left side lying position. The purpose of that is by the time that we'll be inserting the barium, it will flow or it will follow the normal contour of your large intestines in such a way that it will be able to flow throughout your large intestine for visualization. This one is an example of a patient with large bowel obstruction. As you can see, okay, there is narrowing here on this part. Okay, there is narrowing on the part occupied by the barium enema. So that would mean that the large intestine is obstructed, okay, or narrowed down. So again, large bowel obstruction. We also have your gastrointestinal motility studies. So as it implies, motility studies. So this talks about the rate of peristalsis that occurs inside our gastrointestinal tract. So one is your radionuclide testing. In your radionuclide testing, what happens is that the gastric emptying and the colonic transit time are being determined. So common food products, especially scrambled egg, are tagged with a radionuclide substance. And then series of x-rays are taken, or series of images under the CT scanner is being taken, which measures the rate of passage of these radioactive substances from the stomach. So this can measure your gastric motility, the rate of your stomach emptying, and then your diabetic gastroparesis, which is a stomach abnormality related to your diabetes, and then your dumping syndrome. Your dumping syndrome is rapid gastric emptying or too fast gastric emptying. Then we also have your colonic transit studies. As the term implies, colonic transit. So this talks about colonic motility and obstructive defecation syndromes. Okay? A capsule containing 20 radionuclide markers are being administered to our patient. And then our patient is instructed to follow the regular diet and the usual daily activities that they are doing. And then abdominal x-rays are being taken every 24 hours. And the purpose of this is to detect the peristalsis of the patient on the normal course of the day. So usually this test would take 4 to 5 days or until all of those radionuclide capsules were already passed out by the patient. Now, however, in the presence of severe constipation, what do you think will happen? Will the patient be able to pass out those capsules on a shorter period of time or longer period of time? Since they're having constipation, the tendency is that their GI tract is moving slowly. So what happens is that in the presence of constipation, okay, the duration of this study may be up to 10 days. If your patient is having chronic diarrhea, in chronic diarrhea, we may perceive, okay, that these capsules will be released on a shorter period of time. So, series of x-rays are taken in 8-hour intervals, okay, if your patient has chronic diarrhea. Let's talk about your endoscopic studies. So the first type here is your fibroscopy, or also known as EGD. So when doctors would say EGD, you now know that your EGD stands for esophagogastroduodenoscopy. As the term implies, it is for the visualization of your esophagus. Gastro is your stomach, and then your duodenum, part of your small intestine. We also have your small bowel endoscopy, that will be the visualization of your small intestine, your colonoscopy for your colon, sigmoidoscopy for your sigmoid, and then you have your proctosigmoidoscopy, you have your anoscopy for your anus, and then you have your endoscopy through an ostomy. Okay, so if your patient has an opening on the abdominal wall already because of ostomy creation, endoscopy could also be done there. Now, let's talk about your fibroscopy or your esophagogastroduodenoscopy. One of the procedures under your fibroscopy or your EGD is what we refer to your ERCP, okay, your endoscopic retrograde cholangiopancreatography. in your ERCP, this allows for the visualization of your cholangio. Cholangio refers to your common bile duct and then your pancreas or part of your pancreas. So the procedure in ERCP is the same as your EGD, but the thing is there is a small part of the scope that goes towards your common bile duct and then your pancreas. Now, when I talk about fibroscopy or EGD, you should picture a patient wherein a scope is inserted through the mouth of the patient. Okay, and then this scope would go towards the esophagus of the patient to visualize the esophagus, and then the stomach, and then later on the small intestines. This procedure has several purposes. It could be diagnostic or it could be therapeutic. It is considered diagnostic if, for example, you would get a tissue sample and analyze it under the microscope, such as your biopsy. It is considered therapeutic if, for example, it will be used for the removal of stones. Your ERCP can possibly remove the stones of your patient in the common bile duct. That's why your ERCP can be considered as therapeutic. On the other hand, your sclerosing agents is administered among your patients with esophageal varices. So the purpose of the sclerosing agents is to sever the varicosities of your esophagus in such a way that it will be destroyed to prevent bleeding. So it's considered to be therapeutic on that part. Okay, so what are your preparations? If ever your patient will be undergoing EGD, take note that your patient would have a water-soluble lubricant placed through the scope. Okay, so this is your endoscope. Okay, it's a flexible scope, hence the term fibroscopy. Now, your patient may have nausea and then your patient may gag. Of course, the gag reflex would be activated once the endoscope will be able to touch this part of your pharynx. So, for that reason, topical anesthetic such as your lidocaine is given and then moderate sedation through IV is done to your patient. One risk for your patient is desaturation. So when I say desaturation, there may be a possible decrease on the oxygen saturation of your patient. For that reason, patients undergoing EGD are attached to your pulse oximeter. So prior to the procedure, what are your preparations? Okay, so pre-procedure, NPO for 8 hours. You don't want your patient to be vomiting food during the procedure. If your patient will be vomiting food, the risk for your patient is aspiration. Okay, local anesthetic, gargle, or spray is administered. Usually, we are using lidocaine in the clinical setting. Then you have your MAG medications. Midazolam. If you can recall, midazolam, okay, is considered to be a benzodiazepine. This is a benzodiazepine, which is used for moderate sedation. Why are we sedating our patients here? The purpose of your sedation is to inhibit your gag reflex. And also, it may relieve the anxiety of your patient. Because remember, your benzodiazepine is also an anxiolytic. Then you have your atropine. When I talk about atropine, that's a drug, classic drug under your sympathetic nervous system. Okay, so this is a sympathomimetic. As a sympathomimetic, its action is dry. Okay, its action is dry. So it reduces secretion. Okay, in this case, it reduces your salivary secretions, your gastric secretions, decreasing the risk also for aspiration. Then, but, by the way, one thing that you need to watch out for after administration of atropine is tachycardia. Okay, tachycardia. Then you have glucagon. So glucagon is given to relax the smooth muscles. Okay, it's given to relax the smooth muscles. Then the patient is usually positioned on the left lateral position before the surgery. Then, so this is how your endoscope would look like. Then, after the procedure, you need to watch out for the level of consciousness of the patient. You need to monitor vital signs. If there is a sudden increase of the pulse and then sudden decrease in the blood pressure, you might be exploring internal bleeding or hemorrhagic shock for your patient. You need also to monitor oxygen saturation of the patient because it is possible that the airway had been hyperactivated or hyper irritated during the procedure. Then you need to watch out for signs of perforation. So when I say perforation, there might be a sudden laceration of the internal organs there, especially that of the esophagus, especially if you're talking about a patient with esophageal varices. So you need to watch out for pain, okay, presence of bleeding, unusual difficulty in swallowing, and rapidly elevated temperature. Okay, these may be signs of your perforation. Then, gag reflex is lost initially. because obviously we have administered your anesthetics. We have given your mild sedatives such as your midazolam. So you'd expect gag reflex to be lost shortly after the procedure. So what's the implication? Can I give food to the patient? No, not yet, until the gag reflex is returning. Then, minor throat discomfort may be present. So lozenges may be given to the patient, saline gargles may be given to the patient, and then oral analgesic agents may be given to the patient once gag reflex has returned. Giving these things to the patient once gag reflex has not yet returned may result to aspiration. So it's a big no-no on. Then, after the procedure still, okay, you're advising your patient that they're not allowed to go home. Okay, EGD is a same-day procedure, meaning you can get in the hospital today, get out hours from now. But your patients are not supposed to drive. Why? They have been sedated. Okay, and with sedation, you know that there will be safety issues when your patients are driving. Then, verbal and written instructions. Okay, not or, but both. Between the two, if you get to choose, that will be written. Okay, written will be more important here, especially for your patients who have been sedated. Why is it important? Because when you're giving instructions to your patient, the tendency is for them to forget the instructions that you have released to them. So regardless if you're talking to the patient or to the patient's family member, you need to have written instructions. Okay, verbal and written instructions is the best for that. Then you have your small bowel endoscopy. So the same procedure with the fibroscopy. Instead, just the little difference here is that these are able to visualize the small intestine portions. Then you have your colonoscopy. So in colonoscopy, what we are using are larger and longer scopes um, compared to your upper GI endoscopy. So you need to watch out for the following signs. There may be dysrhythmia and over and under hydration. So why is dysrhythmia occurring? Take note, bata, if you're bearing down, okay, one thing that's activated is your Valsalva maneuver, and then it has an effect to your heart. It slows down your heart rate. So colonoscopy, a scope is inserted through the anus, the rectum, okay, going towards the colon. Expect that Valsalva maneuver may be activated. Overhydration, we're preparing the patient for colonoscopy. We're doing enema. Okay, so if there's a lot of enema, it may be underhydration. However, because the patient is on NPO, we place the patient on IV fluids. One risk still is overhydration. So you need to assess accurately the fluid status of your patient. After the procedure, you need to watch out for bowel perforation, meaning a sudden laceration on the bowel, which are manifested by rectal bleeding, abdominal pain or distension, then fever, and then focal peritoneal signs. Okay, so your patient may have rebound tenderness for that matter, and then peritoneal irritation. Okay, which is one complication of your colonoscopy. For that reason, okay, your virtual colonoscopy have been a recent trend when it comes to imaging studies. Okay, so this is how a colonoscopy would look like. As you can see, the colonoscope could reach up to the ascending colon. Then we have your manometry. So manometry, when you say manometer, it measures pressure. So in this case, the pressure that we're measuring is the motility of your esophagus, the upper and the lower esophageal sphincter. So you will encounter diseases wherein there is lack of pressure or lack of peristalsis. One example of which is the term achalasia. Okay, achalasia. So in achalasia, there is absence of pressure. So when I measure the pressure of a patient with achalasia, okay, there is likely none. Then you have your diffuse esophageal spasms also and scleroderma. These are diagnosed using your manometry. If your patient will undergo manometry, take note, okay? What will happen is that a scope will be inserted or a device will be inserted through the nose of your patient, and then attached to the tip of the device is the manometer, okay? The one that will measure the pressure. So what do you think? Can our patient eat before the procedure? Since we will be giving food through the mouth of the patient will be, what I mean is, since we will be inserting an equipment through the mouth of the patient, okay, NPO for 8 to 12 hours before the test. Then medications that could possibly affect the GI movement, such as your parasympathetic drugs, your anticholinergic drugs, okay, your calcium channel blockers, and even your sedatives are placed on hold for 1 to 2 days. Okay, so again, a pressure catheter is inserted through the nose and is connected to a transducer. And then there will be a video recorder that will be recording the pressure of your lower esophageal sphincter. Then we have the term electrogastography. Just think of your electrocardiography. Now we have your electrogastography. So here, this is used to evaluate for nerve dysfunction in the stomach. Okay, so this is used to evaluate gastric motility disorders. Then you have your motor nerve dysfunction in the stomach. So what you're watching there is the innervation of nerves. Then we have the term defecography. So defecate. Okay, we're talking here about anorectal function. So this is performed with the thick barium paste. The barium paste is inserted through the anus of the patient, and then through successive X-rays, okay, or successions of X-rays, which we refer to as fluoroscopy. Okay, these successive X-ray images are taken to assess the function of the rectum and then the anal sphincter while the patient tries to expel the barium paste. Okay, so the patient will try to expel the barium paste using your um, anal sphincter. And then that will help us determine if the anal sphincter functioning is still normal or if the pressure is within expectations. Then we have your gastric analysis. So in gastric analysis, the preparation is that the patient is placed on NPO for 8 to 12 hours. And then you tell the patient to stop smoking because smoking will alter the result of your gastric analysis. Okay? Now, if your patient has pernicious anemia, the tendency is that the patient with this disease secrete no acid under basal conditions or even after stimulating. Whereas a patient with severe chronic atrophic gastritis, okay, atrophic gastritis, atrophy, meaning there is a decrease in the size and the functioning of the stomach. So the tendency also is for the patient to secrete little or no acid. The same may be true in gastric cancer. Whereas in gastric ulcer, the tendency is for the patient, okay, with the disease to excrete some acid. Okay, they secrete some acid. Whereas in duodenal ulcer, it is secreting several acid, okay, or a lot of acid for that matter. We also have what we refer to as gastric acid stimulation test. As you might have noticed, one of the medications that we give if there is increased acid are antihistamines. But in this case, this is gastric acid stimulation test. So we would want to stimulate the acid of the stomach. So we're giving histamine here, and one medication is pentagastrin. So these medications are given subcutaneously. Now, if you're giving this medication as a nurse prior to the gastric acid stimulation test, you need to inform the patient that upon entry of these medications, there will be a flushed feeling. Since you will be stimulating the parasympathetic nervous system, you need to watch out for the blood pressure of the patient and then the pulse in case of occurrence of hypotension. So, the gastric acid specimens here will be collected every 15 minutes for the next 1 hour and then labeled if which of the following gastric acids, okay, are collected during the time that histamine was injected or after histamine was injected. And then a series of tests will be used. Okay, this would also indicate if the stomach would respond to the histamine and pentagastrin. Then we also have pH monitoring. So in pH monitoring, a sample also of the gastric acid is being taken, okay, usually every 15 minutes depending on the reason. And then the patient is usually placed on NPO for 6 hours before the test. And then medications will be placed on hold for 24 to 48 hours if it can affect the gastric acid production. Okay, so normally our stomach is deemed to be acidic, and then your pH monitoring is used to determine the acidity of your stomach and in what time of the day or in what activities the pH of it is more likely to become acidic. Then we have your laparoscope. Okay, so you have your laparoscopic procedure, also referred to as peritonioscopy. So your laparoscopic procedure allow for the visualization of the abdominal contents. So your laparoscopic procedures are considered to be minimally invasive surgeries. Okay, it's considered to be minimally invasive surgery because only a small incision is done to the patient, and then scopes are inserted in the patient's body in order to visualize the abdominal contents or even to perform surgery to the patient. Okay, prior to the procedure or during the procedure, once a skin incision is done, okay, pneumoperitoneum is induced. So when I say pneumoperitoneum, okay, carbon dioxide is injected into the peritoneal cavity. So the purpose of that is to separate the intestines from the pelvic organ, and then it will also aid in the visualization. Okay, so a small incision is made also lateral to the umbilicus to permit the visualization of the organs. So as you can see, this is the scope. There are two other scopes which may be used for cutting, Okay, this one is used for lighting. The other scope may be used for collection of specimen. The laparoscopic procedure may be done to, other than visualizing the organs in the abdomen, it can also be done to get, for example, the gallbladder of the patient. So we have procedures referred to as laparoscopic cholecystectomy. So when I say laparoscopic cholecystectomy, cholecys refers there to the gallbladder, and then tectomy is removal. We also have your laparoscopic appendectomy for that matter. So, here are the nursing diagnoses that we can possibly encounter in our patients who are having gastrointestinal problem. Okay, imbalanced nutrition, less than body requirements, which may be related to decrease intake or maybe increase in the secretion, okay, or too much rapid peristalsis. There may be deficient fluid volume related also to diarrhea of your patient. Your patient may experience nausea related to increased gastric acid secretion. Your patient may have impaired skin integrity related to stoma creation. Your patient may have acute pain or chronic pain related to underlying infection, related to underlying carcinoma, okay, or underlying neoplastic processes. Then the risk for infection related to impaired skin integrity, such as your stoma. Then you may have deficient knowledge related to their diet, okay, related to the food that they are not supposed to take because of their condition. They may also have constipation related to decreased fiber intake, related to decreased peristalsis. The risk for urinary retention related to abdominal pain, okay, related to the failure of the sphincter to contract. Then you have your anxiety or fear related to the procedures that they are undergoing. There may be ineffective coping for that matter related to the surgery, disturbed body image related to stoma creation. There will be sleep pattern disturbance related maybe to the pain, risk for sexual dysfunction due to the surgery, risk for deficient fluid volume due to decreased fluid intake, then activity intolerance due to decreased blood, okay, or decreased blood products, ineffective therapeutic regimen management related to non-compliance, then the risk for aspiration because of not following instructions prior to surgery, then you may have diarrhea and then vomiting as the problems. So this nursing diagnosis will vary in etiology once we are discussing the specifics, okay, of the disorders that our patient will be encountering. So this will be the end of the introductory topics in your gastrointestinal system. After this, we will be discussing the pathophysiologic changes, or in other words, the diseases, okay, under your gastrointestinal system. Thank you very much for your kind attention.